Hello, let's learn about the antimicrobials. Let us learn about the daily activities in stewardship program. Antibiotic stewardship includes the three principles such as selection of the most appropriate antimicrobial treatment, optimization of the drug selection, dosage, and duration, improvement of patient safety to reducing the risk of toxicity, adverse effects, and hospital-acquired infections. The core strategies include pre-authorization of formulary restriction, hospital review, and feedback. Other strategies include education, guidelines, order sets, dose optimization, IV to oral switch, streamlining of therapy, information technology. Institutional programs incorporate multiple strategies and gain cooperation among different professionals. IHI and CDC partnership to organize theories and ideas needed for improvement. It were available at CDC portal, published in 2013. It consists of primary driver for the stewardship program and the secondary drivers. The current stewardship programs, which is a 2-month alternate survey published in 2008, mentioned that hospitals with an established stewardship program differ from those without a stewardship program. Pharmacy-driven stewardship program with antibiotic streamlining and de-escalation and dose optimization is imperative and brings about a significant improvement in the patient safety. Approaches to core stewardship strategy includes formulary restriction and pre-authorization. The procedure is to restrict dispensing of targeted antimicrobials to approved indications. Then the antimicrobial committee to create guidelines for the same. Advantage is that most direct control over the usage, immediate and significant reduction in the usage and the cost. However, disadvantage is that there is a perceived loss of autonomy for the prescribers. The procedure for the prospective audit includes prospective and daily review of the antimicrobials for effectiveness, contact the prescriber to recommend the alternative therapy, focus on activities such as IV to oral switch de-escalation. The person responsible at the antimicrobial committee, person responsible for daily regime review. Advantage is that it is a post-prescription intervention by the clinician given authority, avoid loss of autonomy, or the compliance is voluntary and may be as low as 20% or direct stewardship is an issue. Regarding IV to oral switch, many agents have oral formulas or similar oral equivalents. We do not directed IV antibiotic list and simple guideline for assessing the patient clinical and GI status. For example, fluoroquinolones. Then we have dose optimization, wherein doses are adjusted for renally eliminated antibiotics, addresses unutilized strategies for pharmacodynamic applications. Then we have elimination of the duplicate therapy, conservative ID on frequent combinations, example, Thursdays and cephalosporins plus amikacin for recall and others. Then we will have a nutritional guideline specific therapy, develop and implement once approved by pharmacologic committee. Discrimination of the therapy based on lack of inpatient process, quality empirical therapy regimes on hospital day 2 or day 3 for differential diagnosis. Then de-escalation, one combination if cultures are negative, follow the culture report to de-escalate antibodies with narrow spectrum antibiotics. Discontinuation based on clinical resolution of infection for community acquired pneumonia, discontinue therapy after more than 5 days of treatment if febrile. What to implement and measure low-hanging fruit versus high-hanging fruit? Early and sustained measures are required. The measures' basic performance should be based on initial objectives. Decrease the antibiotic usage, decrease the unnecessary combinations, decrease vancomycin use, IV to oral conversions, increase the compliance with de-escalation, and improve dose optimization. Later, then develop evidence-based guidelines, improve appropriateness, discontinue therapy, institute antibiotic. Approach to core strategies include procedures, personal advantages and disadvantages. Procedures to have automatic stop order approved by the antibiotic utilization committee. It decreases antibiotic utilizations and cost, but however, the disadvantages must be closely monitored. Then regarding the clinical practice guidelines, implementation of best practices should be approved by the drug control committee. It decreases the therapy without intervention, however, it has a longer. Addressing usage of selected antimicrobials may decrease the selection of some ESBL and carbapenems producing gram-negative while also potentially decreasing the clostridium difficile. This could be an initial stewardship step in an outbreak situation. So daily activities to summarize it to create a reliable and the basic daily or weekly or service plan, example ICU rounds and others, ensure the daily activities have high pay of potentials, take advantage of the complex situation which offer multiple points of interventions and should be captured through documentation. Select accurate empirical drug therapy, select dose, select de-escalations, and adequate duration. That constitute the 5 Ds of the stewardship program. along with decreased potential for emergence of resistance. The selected activities of the stewardship program includes education, appropriate duration, parental to IV conversion, drug selection, optimization, guidelines, pathways, and if you see the focus on interventions chart, the broad focus will be on the audit and feedback of all antibiotic orders and hospital guidelines, and targeted interventions will be on audit feedback. 12 potential identifiers to consider for real-time stewardship is core measure compliance, creatinine clearance, identified antibiotics for IV to oral switch, restricted antibiotic list, one commotion more than 3 days with negative cultures, duplicate therapy, pathogen drug mismatch, patients on more than 3 antibiotics, recent positive cultures, antibiotic therapy more than 7 days, one commotion therapy, and disease drug mismatch. Software programs interface with the several databases are the computer-assisted strategies. Software programs augment testing programs in many ways. They identify the high microbial agents, track the disease demographics, identify target patients, consider the patient-specific information, document and assessment of outcomes, communicate and record the ASP recommendations. Problems with traditional interventions include antimicrobial decision making is complex, multiple variables are need to be considered, incomplete patient-specific information, timeliness, patient and considerations and guidelines. The features of the clinical decision support are likely to increase the clinical uptake. The primary determinant of the certification is speed, integrated CDSS with clinical workflow, impacts are monitored, align the guideline developments, and example including implementation of CDSS and the use of computerized acid test surveillance for redundant antibiotic. Impact of computerized physician order enter program targeting the lineage already usage. Role of electronic medical records and technological summary. To begin planning early institution specific IT programming, identify early institution specific templates, work with other departments, network with other practitioners of stewardship program, evaluate the technical support capabilities, work with the department to identify the cost, annual fees. Clinical microbials role plays is very important. The microbials are an essential team member of the program. They incorporate antibiotic data into the point of decision antibiotic prescribing. They create real-time alerts of key pathogens like ESBL, MRSA, VRE, and others. They collaborate in the selection of testing panels and add notes to the culture reports, education to the prescribers, and facilitate the saving isolates for additional testing. This slide is an example of sensitive what to report and what to not to report. Changes in the resistance observed from antibiotic attack cannot be easily linked to effects of stewardship. Antibiotics are generally inadequately designed to reflect changes. Antibiotics include return bacterial isolates. Reporting policies may change, making analysis or time difficult. Resistance has two dimensions: population based and patient specific. Antibiotics pull the same isolates. Antibiotics may fail to study the patient specific group. Beneficial effects in facilitating use may be directed by larger populations. Antimicrobial resistance is multifactorial. Antimicrobial exposure is only one of the many possible reasons for the emergence of spread of drugs in organisms. Good news is that there has been 80% reduction in the cephalosporin use by antibiotic switching, 44% reduction in the cephalosporin in Klebsiella pneumonia. However, the issues is that 141% increase in the imipenem use and 69% increase in the imipenem resistance because of the antibiotic switching. There is an effect of an antimicrobial formulary that affects the change in hospital resistance. Rapid diagnostic testing integrated into the stewardship program may deliver favorable outcomes. And stewardship impact with polymerase chain reaction for MRS and staph aureus has been proved beneficial in stewardship. PCR, that is polymerase chain reaction, used in stewardship interventions for coagulation negative staphylococcus. Then there are even newer toxins that is being analyzed for opportunity stewardship program, such as matrix associated laser desorption and ionization time of flat mass spectrometry, which is a new technology to identify the bacterium waste from agar pet colonies, and within minutes we get the identification of organisms and identification of the resistance. Then procalcitonin also plays a key role as a biomarker of systemic inflammation used in diagnosis of bacterial infection. Summarize, the clinical microbiology laboratory plays a vital role in timely identification of the pathogens, the resistant genes, and identification of molecular investigation of local outbreaks and resistance surveillance. The stewardship includes a clinical microbiologist as an integral member of the program to assist in the prudent use of antimicrobials in development and publication of antibiogram, prioritization of the testing antimicrobials, selective reporting, clonal characterization of resistant and outbreak strains. Thank you.